Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In today's episode, we discuss the fundamentals of cytomegalovirus in kidney transplant recipients. I'm joined by Dr. Marcus Pereira from Columbia University Irving Medical Center in New York and Dr. Raymund Razonable from the Mayo Clinic College of Medicine and Science in Rochester, Minnesota. To see the full program, including the accompanying slides for this podcast, visit the show notes for this episode. Now let's start things off with Dr. Pereira.
So CMV, as you know, cytomegalovirus, is a DNA virus. It's specifically human virus that is really adapted to infect us. And as you can tell, it's got a number of mechanisms or structures like the glycoprotein, the envelope protein, a complex genome, and other parts of the virus. And overall, it's got 160 and more functional genes. And some of the important ones that you would hear about in transplantation, in particular when it comes to antiviral therapies, are UL54, which is the DNA polymerase. It's responsible for the viral replication. UL97, it's a viral kinase, particularly very important for acyclovir and maribavir. And UL5689, which is part of the terminase complex, sort of the final step of the viral replication, which is very important for letermovir. And those are sort of when you think about viral mutations and resistance and the mechanism of action of those antivirals, those are sort of the important genes. On the clinical side, what are the clinical manifestations of CMV? And those will depend on whether your patient is immunocompetent or immunocompromised. CMV in some ways is an opportunistic infection, and its manifestations will really depend on that net state of immunosuppression that we all hear about in transplantation. And in terms of manifestations, there are a few very classic presentations. So one is sort of, or a definition I should say, CMV infection, which is a CMV is replicating in the body with or without symptoms. And then CMV disease, which is CMV replication, and now you're actually sick from the CMV, and so you have symptoms. And that can be broken down into viral syndrome or tissue invasive disease. Now, how does CMV get from an infection to the disease? What are the processes or the pathogenesis of that happening? And as you can tell, in the setting of immunosuppression, it's certainly a combination of the medications that those patients are taking, whether these are the steroids, the calcineurin inhibitors, such as cyclosporin and tacrolimus, or mycophenolic acid, or the cell cycle inhibitors, or mTOR inhibitors, and the other combination or other therapies that our recipients get, anti-T cell antibodies or belatacept, you name it, right? The armamentarium is increasing, and therefore the modes of immunosuppression are also becoming quite complex. In that setting, the virus itself, with an opportunity to start replicating, the viral load goes up. You can have minimum symptoms like the CMV syndrome, for example, and we'll go over what that means. And then the sort of worst case scenario is CMV disease. Now you're really sick with tissue invasive disease. So what are the direct effects of CMV that we generally talk about, and how does it impact our transplant patients? So directly, you have CMV syndrome, which is generally something more related to mononucleosis. This is what I would like to tell my patients: fever, fatigue, malaise, myalgias, or muscle aches. You also have lab abnormalities like leukopenia and thrombocytopenia, sort of a general bone marrow suppression. You can say a mild hepatitis, so elevated liver transaminases. And overall, you see replication of the virus in the bloodstream. Now, tissue invasive disease is a little bit more serious. There is actually end organ damage. So name an organ and CMV can impact, whether it's the liver, the lungs, the heart, the GI tract, the kidneys, the pancreas, or sometimes CNS disease. And those can be quite severe at times. And those are the ones related to most morbidity and mortality as compared to, for example, with CMV syndrome. So, but the sort of aspect of CMV that we generally, in some ways, see most and worry the most, it's not necessarily the direct effects, are the indirect effects of CMV. So when CMV starts replicating in the body, there are a number of downstream effects or impacts on your transplant recipient. So CMV itself can be an immunosuppressive virus, and that has its own repercussions. So now you have additional immunosuppressive pressure on your patient. It can be pro-inflammatory, actually, paradoxically. You're both immunosuppressing your patient, but also creating more inflammation. And that, in its sense, can create alloreactivity, so putting your patient now at risk for organ rejection. And then in the setting of greater immunosuppression, you can now have a direct interaction with other viruses that are prone to reactivate, whether it's CMV, HSV, VZV, and certainly when it comes to EBV, you're worried about PTLD. Now, those are sort of the main issues: opportunistic infections, graft dysfunction or rejection even, and then mortality as well. That's sort of indirectly related to CMV itself. And I'll take the opportunity to actually present some cases to my colleague, Dr. Razonable. So Dr. Razonable, let me read you a couple of illustrative cases. So this is a 55-year-old CMV seronegative gentleman with end-stage renal disease because of diabetes, who received a deceased donor kidney transplant from a CMV seropositive donor, so a D plus R minus. He received induction with anti-thymocyte immunoglobulin and maintained on mycophenolate, tacrolimus, and prednisone. So what are you thinking here in terms of what would you do?
CMV prevention?
Yes.
For CMV prevention, the current guidelines do recommend that you could either do prophylaxis or preemptive therapy if you have the logistics available to perform CMV PCR weekly. Most of the programs still do prophylaxis in this patient population, and your choices in the past has always been valganciclovir, but now we also have letermovir as an option.
Very good, very good. So we'll be talking a lot about those options. So then a second case, 40-year-old gentleman, a woman, CMV seropositive woman with chronic reflux nephropathy, who received a kidney allograft from a CMV seropositive living donor, so a D plus R plus. She received induction with alemtuzumab and maintained on mycophenolate, tacrolimus, and prednisone. So what are you thinking here? Any different from the first patient?
The difference is this is a seropositive patient, so really the risk of CMV is lower, so you could do preemptive therapy or prophylaxis in this situation. If you do prophylaxis, your choice really that's approved is valganciclovir, but that has the nuances of monitoring for renal function just to kind of make sure that the dose is correct. And we will also discuss potentially, currently this is 3 months of prophylaxis, but can you even shorten that with the use of cell-mediated immunity?
So let's talk about some risk factors for CMV reinfection and reactivation. As many of you know, there's a number of them, and certainly many of them are quite important and quite relevant. So first and foremost, as you always will hear your transplant infectious disease doctors talking about CMV, is the serostatus of the donor and the recipient, right? So those Ds and those Rs really are important. So as you know, and then Dr. Razonable said, sort of D plus R minus. So you have a kidney with CMV going into a recipient who has never seen CMV before and has no immunity that's pre-existing to that virus. That's a high-risk situation. Intermediate-wise, you have a recipient who's positive and may get an organ with CMV or not, sort of the D minus R plus or D plus R plus. So that's intermediate. And as you can imagine, the lowest category would be a D minus R minus. I think that's well understood at this point as a major risk factor for CMV reactivation. Then you have the type of transplant, right? Not all transplants are the same, whereas lung and small bowel generally have much higher levels of immunosuppression, therefore creating a greater risk for CMV to reactivate than, for example, a liver transplant recipient. Kidney generally is somewhere in between, although that can change as well. The net state of suppression we talked about, that's sort of a combination of various factors. If someone had major surgery, how sick were they even before the transplant? What medications are they taking? And what other comorbidities do they have, such as diabetes or other problems? Acute rejection, certainly that, and the requirement to augment immunosuppression will change the risk for CMV to reactivate. And I think that obviously is pretty straightforward. And then there are a number of other considerations. So it turns out that not only CMV can cause immunosuppression, but the other herpes viruses, if VZV or HSV or even EBV starts reactivating and causing problem, your patient now has more immunosuppression, and that can actually lead to greater risk of other opportunistic infections. Advanced age, leukopenia, and hypogammaglobulinemia can all be additional factors relating to CMV reactivation. So we talked a lot about sort of the serostatus, right? So the serology is useful pre-transplant for risk stratification, but not useful post-transplant, right? Our immunocompromised patients are not reliable, don't have a reliable immune system to form IgG or IgM in the setting of a new infection. So really these tests are all obtained pre-transplant. And as I alluded to before, the high risk is the D plus R minus. Intermediate would be D plus R plus or D minus R plus. And then the low risk is someone who doesn't get an organ with CMV and doesn't have any CMV in their own bodies to reactivate. They're at risk for primary infection, but that's quite rare in the adult world. So in that setting, the high risk, those patients remain, again, at high risk, both from a humoral and a T cell perspective. And for our D+, our D-, R-, there's a requirement for them to get leukodepleted blood products. So we talked about our intermediate category, those with a CMV IgG that's positive, as intermediate risk. But again, even that, those patients are not all the same. And studies have shown that if you have a pre-transplant CMV IgG that's actually at a low level, right, there's certainly sort of titers to these antibodies. And if your patient actually has a low level or the minimally possible level, they're actually at risk for CMV reactivation. So there is a study in kidney transplant recipients, or 340 who are R+ transplant recipients, and actually they found that the rate of CMV infection was 14.8%, but the risk was highest in those with a very low IgG level, or less than 20 AUs per ml, along with old donor age and anti-thymocyte induction therapy. So those are equivalent risks that modulated CMV from reactivating in those patients. That data was actually statistically significant levels of reactivation. That's not unique to kidney transplant recipients. There is a study also for liver transplant recipients that showed pretty much the same thing. A low positive IgG titer puts your patient at risk for CMV to reactivate. Now, not all of us get titers, right? I only get a positive or negative. But it's interesting to see if your center has a titer available for you to further stratify your patients. And based on the serologic status, it's not only antibody immunity that we consider, right? There's also a whole other arm of the immune system, which is the CMV-specific T cells. And even in those patients, for our CMV seropositive SOT candidates, those with low or absent CMV-specific T cells, they have a higher risk of CMV reactivation as well. And that's where those CMI tests will come into play. Now, going back to the CMV D+, R-, right? This is just to bring the point home that that group of patients really are at the highest risk for CMV to reactivate, and that over and over studies have shown that that remains a major independent risk factor for graft failure and mortality. This was a large study carried out with UNOS and OPTN data between 2010 and 2015 in adult kidney transplant recipients, and they looked at the different serological pairings between donor and recipient. And essentially, in a nutshell, the D+, R- had the highest rates of mortality and highest rates of graft failure. And this is sort of, you're not even looking at those who reactivate and get treated or not. This is just on a population basis. There's something about that combination that's really impactful on our patients. And it's really important for us to think through and make sure that we're doing everything we can to prevent CMV from causing those impacts.
Thank you to our faculty, and thanks to you, our listeners, for joining us. To learn more from our program on minimizing CMV in high-risk kidney transplant recipients, click the link in the show notes. And to get access to all of our new podcasts, you can subscribe to the CCO Infectious Disease podcast on your favorite podcast player. Thank you, and we'll see you on the next podcast soon.